So, NHS Pathways. What exactly is it? Technically, NHS Pathways is a suite of several hundred interlinked clinical question flows, each covering different symptoms. But that's not terribly helpful as an explanation. The best way to describe it: if you feel unwell, you may choose to phone somewhere. 999, GP out of hours. At some stage, someone will ask you a string of questions to determine how serious your condition is, and therefore determine what kind of care you need. Do you have the kind of headache that will kill you if left untreated? Or is it a simple headache that can be managed with pain relief at home? NHS Pathways is a tool to determine what clinical questions must be asked, in what order. Each answer determines the next question to be asked and leads to a predetermined level of care based on the information provided. It has been specifically designed by NHS clinicians and can be used in any setting taking calls from the public, like 999, GP out of hours, and NHS Direct, enabling them to assess the seriousness or otherwise, and match the caller with a service in their local area that can deliver the care they need. Crucially, it knits into whatever infrastructure is already in place. No new systems are required. NHS Pathways is unique in that it includes an integrated web-based directory that can be populated with the skills and services within any given area. As a clinical assessment progresses, certain answers determine that a particular clinical skill will be required by this caller. At the end of the assessment, a unique combination of codes identifies the clinical skills required and the time frame within which they must be provided to the patient. So, if someone calls with a minor wound that is not bleeding heavily, nor in a dangerous place, the assessment may determine that they need someone who can stitch and dress a wound within the next 2 hours. An automatic search will present the call handler with a list of services that are open in the patient area and able to provide the skills required. So, why is NHS Pathways needed? To understand why NHS Pathways is needed, we need first to look at access to urgent and emergency care today. When someone perceives that they have a need for urgent care, they have a choice of places they can call. They could ring 999 if they perceive it as an emergency. They may know of NHS Direct and may have the number to hand. They may be aware that there is a GP out of hours service and may have that number available. Whatever they decide to do, there is a right answer for their situation. Clinically, there is an appropriate level of care. The problem is, none of these access points uses the same clinical approach to determine what is required. That makes it difficult to cross-refer if the patient calls the wrong place, and it also means that each place has to maintain its own directory of the services in that area. 3 types of organisation, each asking local services for information, each gathering and maintaining a different directory. Consistent clinical assessment has been a policy aspiration at local and national level for a number of years. But none of the clinical assessment tools on the market can be used in every telephone setting. The ambulance service uses prioritisation software that aims to identify how fast a vehicle must arrive, but does not support the call handler to identify if an ambulance is actually required. To do that, all calls prioritised to the lowest category are placed in a queue for a call back from the clinician using a separate clinical assessment tool. NHS Direct uses its own tools, and while call handlers are able to identify emergencies and those callers who need urgent GP appointments, the majority of calls go into a queue for a callback from a nurse. GP out of hours services uses a wide range of different approaches and different operational models, but all involve an initial conversation with a call handler, followed by a callback from a clinician, which might be a doctor or nurse depending on which operation model of the individual service. In an integrated urgent and emergency care system, Assessment by one setting would enable referral to the appropriate level of care, without the patient being passed from one service to another. If someone dials the GP out-of-hours service and actually requires an ambulance, they currently have to be transferred to the ambulance service and re-triaged before the vehicle can be dispatched. The first service knows they need an ambulance, but their systems cannot trigger dispatch. It is also worth noting that in all the current places you can call, you are answered first by the call handler, and then, if it is not an emergency, you are likely to wait for a call back from a clinician to repeat everything before you are given information on where you might best seek help. Let's have a look at some patient scenarios to see how NHS Pathways is providing integrated accesses in urgent and emergency care. The first patient is Phil, and he has a nasty cut to the arm. Phil calls an SPA number, and the over-the-phone assessment identifies that it is in a non-dangerous area, and there is no dangerous blood loss. The size indicates it probably needs stitching. The call taker's assessment triggers a search on the Integrated Directory of Services, and the patient is safely referred to a minor injuries unit, with all the facilities he needs, just a mile from his home. The second patient, Stan, also calls an SPA on a Sunday morning after a big fry-up. He thinks he has indigestion, though admits it's never been this bad before. The clinical assessment with NHS Pathways reveals that he also has an aching arm and jaw, and it is therefore not possible to exclude a heart attack. In other places, this would necessitate him being transferred to the ambulance service, who will take all his details again and re-triage him in order to dispatch a vehicle. In this situation, however, the ambulance service also uses NHS Pathways, and the request for a vehicle can be passed directly into the CAD, and the ambulance begins rolling in no more time than if the gentleman had called 999 directly. Our next patient, Dorothy, has dialed 999 because her catheter is blocked, and she always dials 999 because she cannot remember any other number. She needs someone who can unblock her catheter. The Pathways assessment identified this, and the search on the directory identifies a district nurse who can visit her at home to provide the skills she needs. Better and more convenient for her, and for the NHS. And this use of a common clinical assessment tool brings real benefits for commissioners as well. To highlight how this works, let's focus on the two male figures. They're identical in terms of their age, their gender, and the clinical skills they require. They differ only by the PCT that provides their care. Let's suppose that they both call the same contact centre. It could be an ambulance control room, an out-of-hours service, or a single point of access. Wherever they call is using NHS Pathways. The clinical assessment for both identifies that they need someone who can unblock their catheter in the next 2 hours. However, even if they speak to the same call handler, they will get different outcomes. The gentleman in NG32 will get a visit at home from an on-duty district nurse. The other gentleman in NG2 will fare less well. The search on the directory reveals that in this hypothetical PCT, there is no service in primary care at midnight to deliver the skills he needs. So he gets a non-urgent ambulance to take him to A&E in the early hours of the morning. Crucially, the system does not just recall where the patients were referred. The data enables identification of a gap analysis for commissioners, showing the specific clinical skills required by time of day and postcode. It can also highlight all primary care skills that could have been provided in the community, but had to go to hospital because there was no service available. The example set out is based on real life. A PCT funding of a 24/7 nursing service was disappointed with the low number of referrals from the ambulance service. The data was able to show that of the skills they were listed to provide, they had received all the possible referrals. However, it was also able to show the additional referrals it would have received had it also listed specific additional skills. Of those, the ability to unblock catheters was a good example. The nurses on the team were not registered to offer this service, but after a 3-day course were qualified to do so, populated the directory accordingly, and promptly received up to 40 new referrals a week. A small tweak in the commissioning arrangement, based on knowledge of actual demand, enabled a commissioned service to become much more relevant to its patients and its local health economy. There are clear benefits to establishing a common clinical assessment process that ensures patients can be directed to an appropriate level of care on first contact. The patient has a much improved experience, accessing appropriate care quicker and without waiting for a call back. The Commissioner is able to ensure best use of appropriate services. Greater use of trained lay call handlers reduces the cost base of telephone assessment. To date, this is translating into some real tangible benefits. In the North East Ambulance Service, they are avoiding 2,000 inappropriate ambulance journeys per month. This equates to putting 4 extra fully staffed vehicles on every 12-hour shift to provide a faster service for the truly ill. NHS Pathways is clearly safe. In 4 years of piloting, over 1.2 million urgent and emergency care calls have been assessed using NHS Pathways, and there have been no adverse incidents caused as a result of the NHS Pathways assessment. Furthermore, it has been academically evaluated on behalf of the Department of Health by the Universities of Sheffield, Southampton and Swansea. They concluded that the NHS Pathways system was safe and appropriate. As a result of this, NHS Pathways was granted a ministerial licence for use in assessing 999 calls. In England, this is a prerequisite for clinical tools, and NHS Pathways is only the 3rd such tool to be licensed for this use. NHS Pathways has sought hard to ensure it gains and retains the support of the national clinical community. The Royal Colleges and professional bodies were involved at the start, before it went live, providing a full peer review of the clinical content. Subsequently, it has gained the overt support of the BMA and Royal Colleges as offering a potential common front end to urgent and emergency care, and this support has translated into active participation in the National NHS Pathway Governance Group, an independent group chaired by the RCGP and including representatives from all the Royal Colleges and professional bodies with an interest in urgent and emergency care. This group will oversee the maintenance of the clinical content in line with clinical best practice and all relevant evidence. Thank you for your interest in NHS Pathways. Hopefully, the presentation has provided you with more information about the way in which NHS Pathways can help to integrate urgent and emergency care. By working closely with the national clinical community to ensure the clinical assessment rigorously reflects the latest evidence, and with local health communities to map the skills and services they commission, NHS Pathways seeks to offer the ideal combination: nationally consistent clinical assessment, followed by referral to the most appropriate local service in the patient's area. In delivering this, NHS Pathways is offering real benefit to the patients and to the NHS. For more information, please contact the NHS Pathways team at www.connectingforhealth.nhs.uk/systems and services/pathways.